All right, thank you so much. Assalamualaikum warahmatullahi wabarakatuh. Hello, hello, good afternoon Indonesia, good morning and noon Egypt, good day for our friends from all the rest of the world. It must be afternoon and evening in Pacific, Australia and New Zealand, noon and afternoon in Asia, morning now in Europe, Africa, and night in North America, Central America, and South America. First and foremost, thank you everyone for coming. Welcome to this international webinar that is attended by participants from 6 continents around the globe. We are gathering now this day, all nations, citizens of the world, to be united for helping the people against blindness. Welcome to our 25th episode of Distinguished Maestro Lecture. I am Gede Pardianto from Indonesia. Let's start the webinar. To honor the origin country of this webinar, please pay attention to Indonesian national anthem. Thank you very much. Now to honor the origin country of our distinguished speaker, please pay attention to Egyptian national anthem. Thank you so much. Ladies and gentlemen, the great maestro this time will be Professor Ashraf Armia BALAMOUN. He is a master, a friend of mine, a multiple awards winner, the editor, and a game changer. Dr. Ashraf Armia is a consultant eye surgeon for more than 20 years. He is consultant eye surgeon at the Egyptian Ministry of Health. He is shareholder and consultant eye surgeon at Al-Watani Eye Hospital in Egypt. He received a prestigious International Education Award from American Academy of Ophthalmology. Dr. Ashraf Armia is the editor of the textbook entitled Keratoconus, Current and Future State of the Art. He is author of many articles and also speaker, panelist, and moderator in many scientific conferences. Now, he is going to deliver Maestro lecture to participants from more than 25 countries of 6 continents around the world. Wow, that is truly impressive. At this very moment, he will present a very important topic with the title Maestro in Continuous Curvilinear Capsulorhexis. It will be a really interesting topic. Now we are learning from the man who is Grand Maestro in this field. So be prepared. Fellow ophthalmologists, let's pay attention to Professor Ashraf Armia. So Ashraf, we are counting down for you. 5, 4, 3, 2, 1. Time is yours. Lift off. Applause. God bless Ashraf Armia.
Thank you so much, Professor Gerd, for the invitation. It's really a great honor for me to be among all Indonesian and all this region that I really admire their work so much. So let me share my presentation today. I hope that my presentation is seen well.
Yes, it's very well.
So, yes. So, as I always say, that the art of Capsulorhexis is the art of phacoemulsification. If you master this step in your phaco, you are going to make your phaco easy, even if you are facing some complications. So I always give the title of this, it is a door for safe phacoemulsification. I have no financial disclosure about this presentation, but these are my disclosures regarding some companies I'm consultant and speaker to them. So what is the aim of my presentation? Is to teach the excellency of masterclass in challenging situations. You must know what are the rules of Capsulorhexis. These rules to decrease the deterioration when a complication happens. This is the most important. It is not the shame that you have a complication. This is normal for everyone, even for experts. But it is the master class to know how to deal with them in the most right rules. So this is my aim in this. So this is the man behind Capsulorhexis, the famous Howard Gimble. He said that the Capsulorhexis was known as a continuous curvilinear Capsulorhexis. And he put this technique to remove the capsule of the lens from the eye during cataract surgery by shear and stretch forces. He innovated this technique. It is generally refers to removal of a part of the anterior lens capsule, but in situation like a developmental cataract, a part of the lens of the posterior capsule is also removed by similar technique, and I'm going to show all this in videos because at least 34th of my presentation will be videos to make it more appealing to all young ophthalmologists. So, in order to remove a cataract with a modern technique, the capsule of the lens must be open. Definitely, we need to remove the nucleus. In older style surgery, which is the intracapsular cataract extraction, the whole lens and the capsule was removed because there was no era of intralenticular lens to put inside the capsule, or the know-how to do a Capsulorhexis. This was done to prevent the inflammatory response and to lift over the lens material. Since it was all removed en bloc, there was no residual. So at this time of era, usually the patient can wear very thick glasses. But with modern techniques, however, the removal of a particularly old material can be achieved while leaving the intact capsule, which is the most important nowadays. This is important since it provides a barrier between the front and the back, which is very important to separate the vitreous from the anterior chamber and prevent the vitreous from moving forward. In addition, this allows the artificial intraocular lens an ideal place to be located in the eye, which is for me the most important location inside the back, away from the contact of other structures, yet solidly held in place. So prior to the advent of CCC, which is changed to 4C, CCCC, it is central, which is must be central, continuous, curvilinear Capsulorhexis. Central is the most important nowadays. It was before this, it was a can opener approach, was used as a small bend of the needle, marking small incisions around the anterior surface of the lens, forming somewhat continuous hole of the lens. However, any of these rags, which is these rags, it's not good, can promote to tear, can extend to the periphery. But a continuous Capsulorhexis, which is like here, was done correctly, does not have any edges, and any forces applied to the capsule during surgery are distributed, do not result in a tear. So the distribution will be in a circular manner, not in a radial manner. The usual method is to use the same bent needle to begin a tear. As we are used to do in an extracapsular, we just open with the needle, or you can open it with the forceps, as I'm going to show in the video, to begin the tear, like this, and in the capsule, and then guide the edge around the anterior capsule, like this, with either same needle or the forceps. There are advantages and disadvantages of both approaches, and the most surgeon will use both instrument, needle or forceps, in different situations. Like this, we continue it as continuous central Capsulorhexis. As noted in children, often the anterior and the posterior capsule is made. Since the posterior capsule become cloudy, even more common in children than adults, become like this. So this will need a capsulotomy. Since a simple office procedure like YAG laser commonly performed in adults, it's difficult for a child since they cannot sit at the slit lamp machine. So it is better to deal with the posterior capsule at the same time of surgery, like this. Since the vitreous in the children is more formed, much more formed, the less of vitreous loss is common. And it is a solid entity, the vitreous, so you can do the anterior and the posterior Capsulorhexis and do it at the anterior vitrectomy for the anterior vitreous face to open a cavity in the vitreous to decrease the incidence of rise of intraocular pressure. So to do a perfect anterior Capsulorhexis, you either use the cystotome, the forceps, the microforceps, or the femto, or recently also the zepto. And I'm going to show this in videos. So getting the right shape and the right size of the optimal optical outcomes, this is the most important. As I said, it is now 4C, not 3C. It's a continuous curvilinear central Capsulorhexis. It must be central. This decreases the tilt of the IOL, stable for if you put a toric IOL, and if you put a multifocal IOL, you are going to have the best results because the rhexis will be away from the diffractive or the refractive zones. A correctly sized and well-centered Capsulorhexis with a 360 degrees overlapping the capsule edge is most important. This prevents IOL tilt, myopic shift, optic decentration, and posterior and anterior capsular ossification, particularly due to the combination of symmetrical contractile forceps of the capsular bag and shrink-wrapped effect. Very important. If you do it a rexus like this, the IOL will be inside the bag in a central position, and the traction force of the anterior rexus and the posterior capsule will be symmetrical. Before commersing the rexus, the surgeon must place enough viscoelastic. You should flatten the anterior chamber. This is mostly like high viscous, like the viscote, to encounter the pressure of the posterior vitreous. This flattened anterior lenticular capsule, preventing the forward push of the lens by the vitreous pressure. It's like a counter pressure, which can result in a radial tear during the maneuver of capsulorhexis. Don't leave your anterior chamber shallow or loss of pressure. This is the key of success of your capsulorhexis. My first video is going to be how to do the right way of capsulorhexis. In my way, I do the rexus in 4 steps. It's like 4 quadrants, as in this picture. 1, 2, 3, and continual closure of the rexus. If you master it like this, you are going to do it very easily. So I'm inflating the anterior chamber now. Then with the capsulorhexis, go make a snip of the anterior capsule, radial, then hold the capsule and rotate it to 1/4. See, it's 1/4. It's the same as this picture. Then leave it, hold it again, and make the second 1/4, and then stop. So 1/4, 2/4. Hold it again, make the third 1/4, and stop, and make the last one, and closure from outside to inside. This is most important. This area, it must be like this, because this will make the rexus in a circular, curvilinear capsulorhexis, and the force, any force will going to be, it will be like this to inside with no radial tip. This is the most important. I'm going to play it again because this is the most important to know how to do the normal capsulorhexis in the normal situation. Inflating your anterior chamber with flattening the anterior the capsule, make the opening and then radial, hold the capsule, make the first 1/4 and stop, hold it from the end, make the second 1/4 and stop, make the third. Don't hurry in the capsulorhexis, because this capsulorhexis can save you in a lot of bad situation can happen during phacoemulsification. This right size and this right position can help you in. If you load the posterior capsule, you can put your IOL inside the sulcus and do an optic capture. You can do the IOL in the bag and then reverse optic capture. So this capsulorhexis can save you in a lot of complications. So what I'm going to present is a lot of situations. Pediatric capsulorhexis, one of the difficult situations. White cataract, how we are going to manage. Extended capsulorhexis, how to stop and then relocate your direction. If you have a fibrosed capsule, how to manage. If you have a Morgagnian cataract, how to manage. If you have a uveitic cataract, how to manage. If you have a lost PCR, you have a posterior capsular tear, and how to convert it to a posterior capsulorhexis. And then I'm going to present 2 videos of femtocapsulorhexis how to remove it after you do the femto, and using the Zep2 Capsulorhexis. So these are the most common situation that you can face during Capsulorhexis. Okay, so I'm going to start with the pediatric. Pediatric, as you all know, that the anterior capsule is the most elastic capsule you can ever do the urexis. This is very difficult and high instance of extension. So the most important is to keep your force to the center, to keep your force to the center. Because if you did it in the normal way of Capsulorhexis, you are going to end with no anterior capsule, and all the anterior capsule are going to be lost because the extension is very high. So maintaining the anterior capsule is very important, as I'm going to do now. You are going to see. This is a child, 6-month-old, has a posterior polar cataract. Very important in pediatric, you should open with the needle, never with the forceps, never with, because the capsule is highly elastic. Just elevate, very small snip, elevate like this, and then stop. Don't continue with the needle. It cannot be. Hold and traction to the center. Always the traction, you share, you rip and share. The same. See, my force is to the center. If you didn't do this, you are going to lose. See, to the center. Always do it, and it is going to rotate like this. If you put it, all your traction to the center, traction to the center, and make it in a lot of, see? And we ended with a very nice size of the capsule. I'm going to show it again. See, a very nice circular, because in pediatric cataract, very important to do the rhexis, never small, never large, never descending. Why? If it is small, capsular phimosis will going to be in less than 1 month, and you are going to go to operate again, and this is not suitable for children. If it's too large, you are going to lose the IOL because it's going to be pop outside the back. If it's decentered, you are going to have a shift of the IOL, which is more common in children because they have the eyeball is elastic, and the positive pressure in children is very high, and the collapse is very easy. So if you make it central, good size, not less than 4.5 to 5 millimeter, central, you are going to make it easy. I'm going to play it again because it's very important, and I know that is one of the difficult situations. Fill your anterior chamber with a good visco cohesive, make a small snip in the anterior capsule, elevate the capsule up, the anterior capsule, to an area so you can hold it with your forceps. Never continue with the needle, never in children. Always hold and track to the center. All your traction to the center. Make it 5, 6 times because you need a good size. Don't be fast in pediatrics. To the center, hold and track to the center, always to the center. This will make you have the good size, and always your eye on this area to guide your size and centration of the Capsulorhexis. This situation is very difficult. It's a hard cataract, fibrosed and white. So what we are going to do, very important, see what I did before. This is a small trick I'm going to see. I always, before I put my air, because you need to stain. So before I do the stain, I always evacuate your anterior chamber totally from aqueous. This is a key step. If you need a good air bubble, you should evacuate your anterior chamber totally from aqueous. See? Sorry. Evacuate and then inject your air. So you are going to have a very nice big air bubble. This is very important. And then go inside, a small stain, you are going to stain your anterior capsule. Another trick. when you inject your viscous, go inject from here to here, never from here. Because if it's from here, you are going to divide the air bubble and you are going to leave an air bubble in the anterior. So watch and see how I'm going to inject the viscoelastic. From inside, this will guide your air outside. And this is always my technique, the spiral rhexis. What is the spiral rhexis? See? Watch and see. This is a spiral rhexis. I usually go small rhexis, small, enlarging. This is what I'm going to do. Watch and see. Small and rotate it in a very small manner. Don't go for large in white cataract. Make it like an onion. Enlarge bit by bit. And always close it to the center as I'm going to make the rib of the rhexis to the inside the rhexis. This will prevent any extension of the rhexis. And then enlarge it more. You can enlarge it like an onion. See? And you succeed to do it. So this is the most important. If you do it in a spiral manner, you are going to decrease the instance of Argentina flag and also the instance of any extension of your rhexis. This is a very nice how to see early your extension and how you direct your change your direction of the rhexis. Watch and see. So this was my case in the last case of my list. I was very tired, and I didn't notice three things. You can see here the zonules. All the zonules can be seen. See, it's here like here. See, this is not a normal zonules. So when you have a zonules on the anterior capsule like this, these are the areas of extension. I didn't notice, and I was very tired. So this is what happened. This is a slow motion. So I hold the capsule but I didn't close it. See. I reached the zonules. Oh, see, I reached the zonules. See, again. I was not careful. When I enlarge it, I touch the zonule. Once you touch the zonule, it means you are going to extend. So I noticed early that I did wrong. If you didn't notice, if you continue like this, you are going to have radial extension. But I noticed, and then I stopped and redirect my force. See? I'm going to catch it from the most periphery to the center, like pediatric, and then direct your rhexis again. If you didn't notice at this position or this time, you are going to lose the anterior capsule with an extension. So this was wrong from me. I know this was wrong because I didn't notice that the anterior zonules are more anteriorly than normal. And this is the area that can extend in this area. But I redirected and I succeeded to close it in the proper way because I noticed the extension very early. This is very important. Don't say, no, I'm going to go. No, I'm going to. No, you are going to lose the anterior capsule very easily. What about fibrosed capsule? You can see after staining that I have a lot of fibrosis. This is a traumatic cataract, long-standing, and you have a lot of capsules. All areas of wrinkling like this is an areas of extension. So let's see what I'm going to handle this fibrosed capsule. You should use your needle. You cannot use the forceps. So you should start with an area less wrinkling and less fibrosed to have a snip and to separate the capsule from the underlying subcapsular fibrosis. You can see how much the fibrosis of the anterior capsule and how much there is a subcapsular fibrosis. So all my way is trying to find the capsule and separate the anterior capsule from the subcapsular fibrosis. Take your time. This is not a normal case. Always I put it in the middle of my list. Never early, never late, because it needs the most extension. So I succeeded to do this at this point, but I felt that I'm not going to take it like this. It's too much fibrosis. So I used the micro scissor and I cut the anterior capsule with the subcapsular fibrosis. But you cannot leave it like this. See and watch what I'm going to do after this. I just cut the subcapsular fibrosis and the anterior capsule, just to remove the area of highly tight anterior capsule and subcapsular fibrosis. This is the first step. Remove the area that you cannot do Rhexis in it. But I want to do a phaco. So you do a phaco, you should have a curvilinear Capsulorhexis. In this area, it will never be central and circular, but you should have it a curvilinear. So with the microforceps, I just remove the capsule with the fibrosis. Okay, now I succeed to remove this and removing all the fibrosis. And then with the forceps, I am trying to convert the edges of the Capsulorhexis into a curvilinear. See how it is very tough. Take your time. Just hold and to the center. You see there is a traction of the zonules here. Take care of this also. So some to the radial and some sharing. And then you are removing all the capsule with the subcapsular fibrosis to convert it into a curvy. See the sub. See this is removal also of the subcapsular fibrosis. So I succeeded to before this case, I succeeded to remove, to convert it into curvilinear, removing all the subcapsular fibrosis, and then it is a normal phaco as usual. Other case, it's more difficult. So I started with the capsule fibrosis because I found this area I can manage with it. And when I'm trying to do it in this area, it was for me very difficult. So I said to myself, no, I can't go with this way. This way, it will be difficult for me. So I changed my mind and I am trying to do it from the opposite way, like this. But see, it's very easy. It can extend very easily. So I am stretching like this, with ripping to the center, and then I can find the edge of the rhexis, and I'm going to bypass this fibrosed area. You can see now, always I put it in the center to prevent any extension, and hold it again from here to bypass this area of fibrosis. It's not an easy because it can extend very easily. So I usually track to the center. You are not aiming for a circular in these cases, only for curvilinear. So you can see I'm removing the rhexis with it can extend very easily. So I track to the center, but it extends also here, but I take it to the center, and then I felt that I will not be able to continue because too much zonular traction. So I make my the micro scissor. I take a snip and trying to remove it from this side, and then I succeed. So I finished by curvilinear Capsulorhexis, and I can do my phaco now. What about Morgagnian? What is Morgagnian? Morgagnian means that the whole lens material is liquefied and only very small nucleus, very hard in the capsular bag. So what is the difficulty in Capsulorhexis? It is a milky white, and to do a good Capsulorhexis, you need a counter pressure. So you do a counter pressure, the capsule should be inflamed. But see what we are going to see now. Staining, very important, and you are going to put the needle to aspirate. There is no lens material, only Morgagnian lens inside the bag. So it's very difficult to do the rhexis. There is no counter traction. So always traction on the sinews. So at this point, see, what I did. To continue this rhexis, you should have a counter pressure. To have a counter pressure, you should inflate your empty bag with a helon, like a visco-cohesive substance, to inflate your bag. It's like a normal lens, so you can continue. This is what I did. So when I inflate the bag, I succeeded to do the rhexis in this very, very zonular weakness, because it's long-standing Morgagnian cataract. Again, I'm going to play it again because this is very important. With the needle, go aspirate all the liquefied material, Then injecting helon inside the capsule, starting your Capsulorhexis, always traction, because you see a lot of traction on the sinews, because it's a laxity bag. There is no material inside the lens, in the capsular lens. So inject more visco-cohesive inside the capsular bag. This will make you succeed to do your rhexis and continue, and then continue your phaco. Okay. More difficult situations. This is a uveitic cataract. Uveitic cataract, one of the challenging situations, because you have a fibrosed anterior capsule, you have a lot of adhesion between the iris and the anterior capsule, and in all uveitic cataract, the Capsulorhexis should be of good size. This will prevent the very early capsular phimosis and decrease the inflammatory response between the iris and the anterior capsular edge. So in these cases, this is a Behçet disease case, uveitic capsule. First, you should remove your adhesions in the right way. So all the posterior synechia between the iris and the anterior capsule, you should remove it clearly before you dilate the pupil. Because as we know, in uveitic cataract, it's very hard to dilate because of the adhesions. So with the visco cannula, I usually remove all the adhesion like this, and then I put my Malyugin ring. Malyugin ring in uveitic cataract is more forgiving than the capsular hooks. So I put my Malyugin ring. Why? Because I need to have a good size of the rhexis. And then I stain the capsule. I found that there is a lot of fibrosis of the anterior capsule, which is very common in uveitic Behçet diseases. So as we all know, that all these wrinkles are the areas of extension in fibrotic cataract. So with the capsular forceps, I started to small snip in the middle. It's not an easy, as we all see, all the lens is moving, so take your time. I didn't cut it, I did it with the needle, I open it. Then take your time during the Capsulorhexis, because you need to have a good size, see? Take your time, sharing and reaping. To have a good size in uveitic cataract is very mandatory. Take your time, see? It is not an easy issue. It is not an easy issue, but all extension. I'm going to say it to play it again, because this is one of the difficult cases. After I remove, I put my Malyugin ring to dilate the pupil. Never go with a small pupil in uveitic cataract. This is the way I put my Malugan ring. You put the at 6 o'clock. Then with the second, I hold the 2 points at 3 and 9. And then this is the only one left. And you put it like this. I started with the Rexus forceps. I couldn't open the capsule because it's highly fibrotic. So I removed the capsule with the needle. I open. And then start bit by bit. You should stop at every point of the fibrosis and look if there is any extension. You should stop directly and hold it again. See, as I feel that it will going to extend, I stop and then continue bit by bit till you finish it, and always make your traction to the center to prevent the extension. Okay. What about posterior rexus in children, especially in children? This is usually my technique, which is prescribed everywhere, but I'm going to highlight it in a very nice way. After you finish your anterior rexus, you remove all the cortex in the back. Inflate your back with a visco-cohesive. See, I'm going to do it. I'm going to inflate the bag with a visco-cohesive. Then, small snip here. Okay. Then you should stop. And then I'm going from this area to ingest visco-dispersive to separate the posterior capsule from the anterior vitreous face to have no traction during the Capsulorhexis, as you're going to see now. See, look and see the wave. Visco-dispersive, see, this is the wave of the visco-dispersive separating the anterior vitreous face from the posterior rexus. And then you can continue your rexus like the pediatric of the anterior, slowly, bit by bit, and you are finished with a very nice posterior rexus. See, this is the posterior rexus, and this is the anterior rexus, and they should be different in sizes between the two. If you do the anterior rexus about 5.5, the posterior rexus should be 3 or 3.5. This is the most perfect size of the posterior rexus. This is another case of posterior polar cataract that I was know that is posterior polar cataract, but the anesthesia was not good, so always the eye was up. I choose to sit temporarily, but this situation always was not easy for me during all the surgery. So I'm trying to do see, always with the second, I am trying to centralize my eye globe. I said, I'm an expert surgeon, don't worry, I can do it. This is wrong, what I said to myself. Okay, I succeeded to finish everything is okay, remove the nucleus, and during the IA, the position, my situation was not good, so I am removing all the cortex, and now I forgot that it's a posterior polar cataract, and I didn't notice, so I tried to polish more and more the posterior up. I opened the posterior capsule in this point. So once you see this, you should stop. Don't go out. Never go out. If you are going to go out, you are going to go out with the aspiration, and then the irrigation is still on because there is no vitreous, and you don't want the vitreous to come. And the vitreous will never come to the anterior chamber if you have a strong pressure of the anterior chamber. So what I did, I removed this, go out, and put my visco-dispersive, inflate the bag, See, I'm inflating the bag and then remove my irrigation. More visco, because this is an opening with a flap. And this I can convert it to a posterior Capsulorhexis, and I can implant in the bag or in the sulcus and then do a optic capture. You see how I'm going to convert? Look, injecting more visco dispersive, and then I'm going to, with the, again, it's a viscote. I'm going to hold the flap and then converted the posterior opening into a posterior Capsulorhexis. This will make the problem for me very safe because it is a posterior Capsulorhexis, a continuous posterior Capsulorhexis. What I'm going to do with this material, I'm not going to hydrate anymore. So with the dry aspiration, I'm going to remove the rest of the cortex like this with no vitreous. This is not vitreous, this is the visco-cohesive, because the edge of the posterior capsule is intact with no traction. Injecting more visco-cohesive, and then I'm going to inject my IOL inside the sulcus and doing a posterior Capsulorhexis, posterior capture, as you are going to see now. Injecting my 3-piece IOL injecting 3-piece IOL inside the sulcus above the anterior capsule, but I have a good Capsulorhexis from the start, and this may save me. And then I'm going to press on the optic like this and doing my posterior capture of this optic to the under the anterior capsule, as you are going to see now. I did the capture, and then safely I can remove everything, and I save the bag totally. And this, the posterior rhexis, and I capture the anterior capsule and leave it like this. Okay, what about the Femtorexes? I do femto cataract in some situations, in some cases of subluxated, spherophakia, microspherophakia, and very, very, very hard cataracts. But other than this, I don't go for femto cataract. So this was, this is how we in the machine, you can see the cornea, the lens, and you adjust your size and the amount of femto species like this, or more like this. You can either divide it in pieces, or also you can chop it very small quadrants like this, and this is how it looks post-operatively. But the most important, how to remove this rhexis. Very important, when the rhexis is done by the femto, you should be aware that the rhexis is already separated from the rest of the capsule, and you should see when you remove the rhexis that there is no tags. See what I'm going to do. Inflating the anterior chamber is very important. Then with the Capsulorhexis, I try to separate the rhexis from the edges like this, from here, from all the quadrants, and then catch the rhexis, and see what I did from inside, because this is the most dangerous area, and put it on the cornea and examine the anterior capsule. You should see that, as we do in a smile, you should see that the rhexis is complete with no text and it's totally complete. This is very important before you continue your phaco. What about Zepto? Zepto is another way to do the capsule with suction and cutting of the anterior capsule in a more circular like the Femto exactly. And this is the picture. This is the Zepto instrument, and this is how it looks. Very clean cut, very nice way if you have this machine. So how you do it? Let's see. You do it like this normally. See, you inject your viscoelastic. This is the machine. You go inside, then it inflate like this. You put it on the anterior capsule, you centralize it, and then you apply suction, and with the foot switch, press stick. It's cut. Now it's cut, and you can see the air is coming from here because it's vacuumed. And then press and done. One step. When you go out, you have a central Capsulorhexis like this, and it's very nice if you are going to do a multifocal IOL. It can save you also in a very difficult situations. If it's a little bit subluxated, you can see it. See, apply the vacuum so the air is going out. Apply your foot switch, tuck. It will going to cut the anterior capsule directly and go out. And you can see it even in, you can see very nice, well centralized Zepto. It's very nice machine. And if you have it, it's very nice. Another case, go, and it's highly forgiving if it's little bit decentered. So go, apply your the Zepto machine, go inside, remove the air from vacuum, and then apply the power, and you can go. It's very nice. I make the Capsulorhexis very easy, but for me, I love the manual because it is the how you can do it. And see how it's forgiving even if it's decenter rhexis, but the IOL is central. This is the beauty of this technique. So my home talk message is the best anatomical and physiological place of a posterior chamber IOL is inside the back to give the best vision for the patient. So do not lose your posterior capsule easily, and also don't lose your anterior capsule. To do this technique, rhexis, you should have a good microscope, good depth of focus, and high magnification. Good instruments with a plenty of viscodispersive type, a good amount of patience, and still functioning coronaries, as we always say. So I also encourage everyone in the field of keratoconus and cornea to have this book. It was a very nice book from all over, 38 co-authors from all over the globe who are experts in the field of keratoconus. It was shared with my friend Cosimo Mazzotta as editors, and a lot of co-authors from all over the world. Thank you so much, and waiting for questions.
All right. Thank you so much, Professor. What a lecture. That was super fantastic.
Thank you so much. Thank you.
Thank you so much.
Thank you so much.
Thank you so much. Do you have many time, Professor? There is
yes, I have 15 minutes. Yes.
6 from Iran, 1 from Malaysia, and 1 from Indonesia.
Okay.
Okay, fellow ophthalmologists, now we are approaching the question and answer session. So, Ashraf, I will read each question for you. So exciting. Okay. The first question from Dr. Morteza Mortazavi Fard from Iran. Do you consider sharing and ripping maneuver for creating Capsulorhexis? Thank you.
Yes, I consider sharing and ripping Capsulorhexis in 2 situations. pediatric capsulorhexis and cases of fibrosis of the capsule, because you are going to combine shearing and ripping during capsulorhexis. Other than this, if it's normal eye with no signs of abnormality of the anterior capsule, just shearing will be great.
Okay, thank you so much. The next question from Iran too. What is your preferred device for capsular access, forceps or cystosome?
I have no financial disclosure, but the most preferable for me is Duckworth and Kent Capsulorhexis forceps. I like the crisscross, and also I like also the mini Capsulorhexis that opens only 2.2. There is two types of normal Capsulorhexis. One opened widely and one open small. The opening, the area of the range of opening is very small. I like the area of area small because it makes me go easily and don't, because when the rhexis open a little bit no wide, you don't lose the viscoelastic inside the capsule, inside the anterior chamber. This is very important.
Thank you
and
so
also
much.
I like the curved one. It's very, very good. The curved makes you reach the anterior capsule easily.
Thank you, Professor. The next question from Malaysia. Excuse me, Professor. Have you compared which one is better, between clockwise or counterclockwise maneuver? Thank you, Professor.
I used to do the rhexis in clockwise. I never do it in anti-clockwise unless I need to do this. But for me, as a right-handed, the clockwise is more easy situation.
Thank you, Professor. You have shared about your experience in Zepto Capsular Axis. Have you any more experience to explain about Zepto Capsular Axis?
Zepto Capsular Axis is very nice. It's very nice tool, and it can save you in a very difficult situations. And if you are not so expert in capsular access, it can help you a lot in doing the anterior capsular access, but it's a costly machine for sure. And you are going to overload on the patient for a cost. So if you have this type of patients that can pay, Zepto is a very nice solution. But I always say manual capsular access is the talent you should be a master of, because you are a surgeon, not a machine. So all your skills that God created inside you, it's in your hands. So don't lose these skills.
All right. Thank you so much. The next question will be from Iran also. What is your preferred capsulorhexis size in pseudo exfoliation? Do you recommend routine CTR or in this case?
Very nice, very important question. Pseudo exfoliation, we have two ways to do to manage these cases. Either you put your IOL inside the bag or in the sulcus. There is two schools. If you are going to put it, if you see that the capsulorhexis, the pseudo exfoliation is not extensive, the perfect size is 5.5, and then you put your CTR and then 1 or 3 pieces inside the bag. If you find that the pseudo exfoliation is a little bit more, put your CTR inside the bag, but put your 3-piece IOL in the sulcus, then do a posterior optic capture. This will decrease the pressure on the zonules for a long time, and using the 3-piece of IOL in the sulcus, very important, because if any time in life the lens gets subluxated, you have already 3-piece inside the bag. You can fixate it by Yamani technique in any time.
Thank you, Professor. The next question, do you change rhexis centration based on pupil center or angle kappa?
Very tricky question. Angle kappa or angle alpha, for me, I don't care about, except for diffractive multifocal IOLs. Other than this, you should central your rhexis on the optical axis, because the centration of the rhexis in the centration of the lens. This will make the lens stable for any time. Angle alpha or angle kappa does not differ from the centration of the IOL, centration of the rhexis. It differs by the centration of the lens in cases of diffractive multifocal, but in large angle kappa, not the normal or the medium side increase angle kappa. But the centration of the rhexis should be on the centration of the lens capsule, not the pupil, not the visual axis.
All right. The next question from Indonesia. Dear Professor, do you have any tips about how to perform CCC in subluxated cataract? Thank you.
In subluxated cataract, it depends on how much the subluxation is. If it is 1/3 of the capsule subluxated, so you can do your rhexis normal. But if it's more than 1/3, you should open with a needle, make your first 1 quadrant, then start to put your capsular hooks to support the area you did it, and piece by piece, you do the second fourth and put another capsular hooks. You are supporting the part you are subluxated lens by the capsular hooks till you continue the rhexis, and you put the 4 capsular hooks to continue removing the cortex and the nucleus and the cortex. Then you put either the segment and suture to the sclera, or you put a modified Sioni ring by 2 holes and double fixation on the sclera.
All right. Thank you.
And always take care in subluxation. If you have a vitreous in the anterior chamber, you should remove the vitreous before starting the Capsulorhexis, either from the anterior approach or the pars plana approach, because the presence of the vitreous in the anterior chamber in cases of severe subluxation will never let you do a nice Capsulorhexis.
We still have time, Professor.
Yeah.
This is so exciting. The next question from Dr. Mortazevi from Iran again. What different tips do you recommend for posterior Capsulorhexis versus anterior Capsulorhexis?
I think he means that you do the Capsulorhexis posterior by the occutome, I think, instead. I don't like to do the posterior Capsulorhexis by the occutome from pars plana vitrectomy. I usually do it from the anterior approach. I like to do it fashionized like the anterior rhexis. Some put the IOL inside the bag, then decenter the IOL, make it shift to the one side, and with the occutome, you can do it. Yes, this is another technique, but my preferable technique to do a good posterior rhexis from the anterior approach, and then you put your IOL inside the bag or sulcus and posterior optic capture.
All right, thank you so much. And then the next question, what instrument is good to do posterior Capsulorhexis?
What you are doing with the anterior Capsulorhexis is the same as the same forces I'm using. I use the technique, the most important, to put a visco cohesive above the posterior capsule to flatten it, then small snip of the posterior capsule, injecting visco dispersive behind the posterior capsule, and then you do the posterior rhexis as the normal, but the size of the posterior capsule should not increase than 3.5 millimeters.
All right. The next question from Dr. Abel Ebong from MUST. Thank you for the presentation, Professor. What precaution do you take when doing CCCC in patient with weak zonular spot and pseudo exfoliation?
Yes, this is if I finish the rhexis and I found that there is a severe pseudo exfoliation, you should put a CTR, very important. Segments you should consider, because the beauty of CCCC is to be perfect. So if to make it like this after the operation, the whole bag should be central. So centration of the bag either by CTR or by modified CTR with the holes, and you can suture the segment, the CTR to the sclera. This will make the bag central, and then you are going to find that your rhexis will be CCCC, and then put your IOL.
Thank you so much, Professor. The next question from Australia. Dear Professor Armia, how do you avoid and to manage the Argentinian flag? Thank you for your explanation, Professor.
Very nice question, because there are 3 types of white cataract. The problem in white cataract that the lens is big and the fluid is behind the back. The fluid is behind the lens. So once you open the anterior capsule, the fluid behind the lens will push the lens forward, and then Argentinian flag happens. So you should differentiate this before the start. If you couldn't differentiate, so the most important step method to prevent Argentinian flag. First, staining of the anterior capsule. Secondly, viscocohesive to flatten the anterior capsule and push the lens back. Third, go with the anterior, with the needle, the insulin needle, aspirate the fluid, and then push the lens, the hardness of the lens back, aspirate more and more and more, till you find that there is no fluid coming from this very small, tiny opening. Once you finish, continue the rhexis in the way I show, the spiral rhexis, because the spiral rhexis will make all the traction circular, 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 and never to reach the extension. Argentinian flag happen when you go and enlarge it from the start. The fluid will come, push the lens up, radial tear happen. So if you make it small, you are not going to have Argentinian flag if you do the same way I did.
Thank you so much. This is very helpful. Thank you, Professor. Maybe this is the last question from Dr. Tommy Tiratmaja from Tanjung Pinang, Indonesia. Thank you, Professor. How to do CCC on a lens that has seep or dislocation? Sometimes the capsule is a bit sticky. Thank you so much.
In subluxation, he means subluxation?
Subluxation and the capsule being sticky, little bit sticky.
Yes, this is true. In subluxation, as I said, rhexis, to master the rhexis, you should have a counter pressure from the zonules, from the posterior vitreous, from the thickness of the lens as it created. So if you lose the zonules, this makes the capsule wrinkled or has no force. So when you start, you find that the capsule is a little bit floppy. And once you catch, it can extend. So the most important in subluxation, to find where is the subluxation. Then you start with a small area and then hold the capsule with the capsular hooks piece by piece. Or there is another trick. Use 2 microforceps and do the rhexis in bimanual. Open and then hold the anterior capsule with the forceps, and then continue the rest of the rhexis bit by bit, changing your hands. So you are using inside the anterior chamber 2 microforceps, and area of laxity, you hold it with the forceps and then continue the rhexis with the other hand, as you do it in bimanual technique.
All right. Thank you so much, Professor. So super. Many questions have been answered by our super maestro at this very moment. Great speaker, great audiences. So phenomenal. Thank you so much, Professor.
Thank you so much. It was a pleasure being with you. Thank you so much.
Thank you.
Thank you so much.
Thank you. Well, here we are spreading love, care, peace, and tranquility on earth. Thank you, SMAC Group. Thank you, ID, Perdami Sumut, Anak Sudarti Foundation. Thank you, all committee, Dr. Diah in Medan, and Hafiz in Jakarta. And thank you so much, our distinguished participants from many countries around the world, especially from Iran and from MUST. And to our maestro, Professor Ashraf Armia BALAMOUN, please send our regard to your family. Thank you so much, Ashraf. Shukran khairan katsira, Professor.
Thank you so much. Thank you so much.
Thank you so much. You are absolutely exceptional. Thank you so much, Professor.
Thank you. Thank you so much.
So our distinguished participants, on January next year, we have next webinar will be 26th Maestro lecture. Hopefully we will have Professor Antoine Brisson from France. Furthermore, the certificate for this webinar will be sent hopefully before 2 weeks. Hopefully before 2 weeks. And your participation is highly appreciated. See you all. Thank you so much, all of our friends from all the rest of the world. And happy holidays to all of you. Wassalamualaikum warahmatullahi wabarakatuh. Thank you so much.
Thank you so much. Thank you.
Thank you so much, Professor. Thank you.